I guess, Nid, I'll lead off with a question, and of course we welcome questions from the audience. We do have one that we'll get to. Nid, the guidelines don't just deal with treatment decisions, they deal with things like post-treatment monitoring. And one stark contrast that I have found in the ASLD and European guidelines is that ASLD calls it a ball game at SVR 12. They say it's okay to stop following. I think EASL has it at 48 weeks. Which are you?
So EASL says any time after week 24. I think that's exactly what it says. So I'm week 12. Listen, I'm so busy that if somebody is non-cirrhotic and is cured and their week 12 HCV RNA is negative, I'm like, adios, bye-bye, follow up with your primary care doctor and get it checked again in a year. I think the data now on SVR12 is incredibly convincing. When they looked at the series of patients who were treated in the soft-lipid ion trials, and they looked at the disconnect between SVR12 and SVR24, there were 12 patients out of 3,000. 7 of those 12 patients were reinfected with a different genotype and or strain, which shows a 5 out of 3,000 relapse between week 12 and week 24, which is less than 0.5%. So it's 99.8, I think it is. So I don't do it. I know the guidelines say you should do it, but in the non-cirrhotics, I don't do it. Of course, I follow all my cirrhotics long term, so it doesn't make any difference.
David, with respect to the real-life data, there's always one parameter which seems to be linked to lower sustained virologic response rates, treatment experienced patient. Is it really treatment experienced? Is it the previous regimen, or is treatment experience just a surrogate of being older, of being more likely to be cirrhotic, or being more likely to be less compliant?
So I think like everything in life, it's a combination of probably both. You know, I think you have to really differentiate treatment experience from a NS5A inhibitor or DAA or oral regimen. Obviously, that has, you know, baseline resistance issues. But actually, Nid and I were talking about it, looking at the data sets from Graham. You know, it's very clear that the only group that really gets disadvantaged is the treatment experience that requires the ribavirin, and usually the cirrhotics. So I think in most of the data sets, it's not just the treatment experience, it's the treatment experience plus the cirrhosis. So I think there's something unique about the treatment experience population. It's a very interesting discussion on, do we do something to the virus, this ribavirin resistance? And I don't think it's just that they represent all the negative factors, because those can be taken out in a multivariate analysis.
So you opened just the other critical question. I just mentioned the European guideline recommends ribavirin in any cirrhotic genotype 1, while the US guidelines actually are very strict according to the data, also to the Mark Bullier meta-analysis, that ribavirin is only required in the cirrhotic non-experienced. And then you have Graham here saying in the experience, they have had ribavirin up front, so the risk that they are resistant to ribavirin makes them actually less eligible to receive ribavirin. So that's a big contradiction what you generate here, and what is really a correct recommendation. Graham, EASL, ASLD guidelines.
I think we just don't know at this stage, and the impact of ribavirin is subtle. It's 4-5%. Without a proper head-to-head trial, without taking account of all these other variables, I don't think we're going to get the answer. But I think in clinical practice with the cirrhotic patient, your goal has always got to be getting that patient over the line. And if that means paying the price of a little bit of ribavirin for the 12 weeks, I would push that way. I think the margins are so small, there's no statistical significance virtually in any of the studies without ribavirin. But I think in the cirrhotic patients, the trend is towards benefits in retreatment with ribavirin. So I'm a great believer in throwing it in. I wouldn't bother in the patients who are going to get 24 weeks. So for patients with hemoglobinopathies, I would drop ribavirin and go for 24 weeks instead of 12 weeks plus riba. But I think, despite my concerns about retreating with ribavirin, the data suggests that you can do it and get away with it. So I'm a big riba fan in those patients. Nid, you throw it in?
I would totally disagree. I would totally disagree with you, Graham, because you're boring. You know, the issue here is that, in fact, The data, as you just said, box data, which is all our meta-analysis, the ION trials didn't show 12 weeks for naive you need ribavirin. More importantly, what David showed really shows you why you have to stand back a little bit. And that is that he took the SimSoft data, where there was all this discussion of do you need ribavirin in cirrhosis and all this, and made a data set that was 10 times larger than Cosmos and showed you don't need ribavirin. Next November, we'll tell you who's right, because we will have thousands of patients in our real-life data sets who have cirrhosis, and they'll be naive, and some will be with, and some will be without ribavirin. And the reality is that 60% of U.S. treatment that we follow is still in cirrhotic patients. So we'll answer that question, but I think this is an area where, in the U.S., ribavirin is getting harder and harder to use. We're not as hearty as the Germans, we're not as tough as you guys, so we don't like ribavirin.
You won't get an answer, did you? You won't get an answer. We'll still be discussing this in 5 years.
Well,
because
you'll be discussing it because you've got nothing else to do, but it'll be irrelevant.
But you won't. Your data will be dramatically flawed because all of you guys with the tough patients will get ribavirin because that's the group you believe it works in, and all the easy cirrhotics with borderline FibroScan scores, are you going to drop it? So what you'll end up with is a very biased data set that will be uninterpretable. But you'll try and sing the song and tell the story, because you will, but it won't actually stack up scientifically.
I would just throw some reason into this discussion.
Why bother?
I think it's mainly an economic argument. Almost every case where we're adding ribavirin, we're trying to go from 24-week, where the data shows that they have almost 100% cure rate, and we're trying to duplicate that with shorter-term therapy. And there's a lot more pressure in Europe. The pressure is gaining in the U.S., and I think that's a discussion that I have with the patient. If we can get 24 weeks, I wouldn't put you on ribavirin. If the payer just gives us 12, we're going to put ribavirin. So to me, it's about economics, and because I don't think we'll ever have the true data sets to know exactly, because that would be a big population study to show a really small difference.
David, will you have enough data from your target trial also for the EPV regimen, whether or not ribavirin is required in the 1A infected patients? Because just for curiosity, Graham, if you just take the trial, the Sapphire trial, and you look for plus or minus ribavirin, and you just take the European patients, 1As have exactly the same SVR rates with or without the ribavirin. It's just the US population which requires apparently a little bit of ribavirin, which is not statistically significant. Yet it's in the label that you should use ribavirin in the 1As. So are you going to answer this question as well in the target registry? Whether or not it's really needed?
I doubt it, not because of anything other than the massive changes that have occurred in the payer mix in the US. So everyone is trying to understand how we're going to get a large international Bikira target set. But it's currently sitting somewhere between 8 and 15% market share in the U.S. Certain places in Europe use it more, and we're doing all we can to get more patients. But I don't know what Anyway, the bad thing about real-world data is you can only reflect the real world. And therefore, we can get great data if people are using certain regimens, and especially if there is big input of those regimens quickly. For regimens that are slow to uptick or in niche areas, real-world data is a much slower process and probably not as helpful.
David Bach, the other David. I think the amiodarone story is an incredibly important cautionary note. It teaches us a lesson about post-approval interactions that we might not have suspected or known about. If you think about the potential mechanisms of action for that interaction, are there any other drugs out there that the amiodarone story makes you say to yourself, gee, if that happens with amiodarone, we better be careful about X?
I mean, I think the concern has been, are there other class 3 antiarrhythmics? Dronedarone is another drug which is closely related in one sense. In another sense, it isn't, because amiodarone's got such incredibly long half-life. Dronedarone is much, much, much shorter, so it is a different drug as well. So I don't think you can automatically say because something's happened with amiodarone, it's going to happen with another of those antiarrhythmics. But it is a cautionary note. When we started those EASL guidelines, they were all green, and they went to ambers, and then they went to reds within a few weeks. So I think, and again, I mean, I don't know all the details of these two cases that Graham in that paper, but potentially it could be a drug interaction, which is quite those patients were complex patients.
David, I think it's very important that you made the point that amiodarone is such a long half-life drug, and that a typical mistake I see in my fellows that they stop amiodarone and think they can start the antiviral therapy 4 weeks later. That is far too early. You really have to wait, how long?
Well, I think you've got to wait at least 8 weeks personally. I think it's something more like 8 weeks.
We rather recommend 12 weeks just to be on a safe side. We have one question, drug-drug interaction, sofosbuvir, metformin, no interaction to the best of my knowledge. Would you agree?
Sofosbuvir and metformin, there's no evidence of an interaction so far between sofosbuvir and metformin. Metformin is normally around a renal transporter, but sofosbuvir undergoes filtration mainly so.
And if you say that the amiodarone mechanism of action may be a shift from a bound to an unbound fraction, would that be affected by the serum albumin levels? And would you expect this to happen more easy in patients with decompensated cirrhosis and low albumin? Or would you think that is unrelated?
Well, it could be related, but it's, we've put forward that as a theory, and it really does need some hard evidence to back that up. I mean, I think 3 or 4 mechanisms have been put forward, hard evidence now to say how can we go forward and understand that. But potentially that could be a factor as well.
We have more questions, but no more time. 98. Would you like to conclude?
I think it's been a great session. I have more questions, but I'm not going to ask them in the interest of time and to be fair to the speakers later. I'm sure all the speakers will be amenable to an approach from anybody in the audience if you'd like to ask them something. Thank you very much, gentlemen.